coming to question 8. A 55-year-old male posted for colonoscopy has a CBC that demonstrated leukocyte count of 8,200. HB is only 6.7. Hematocrit is 21%. Platelet is 240,000. Is admitted for further workup and transfused 2 units of PRBCs. Approximately 2 hours after the transfusion, it develops sudden onset dyspnea and evidence of cyanosis. Is quickly intubated and his vitals were as follows: temperature 38.2, okay. Pulse rate shows tachycardia. BP is showing hypotension, borderline hypotensive, at least he's in shock. And physical examination shows he's tachycardic with a normal S1, S2 and has no jugular venous distension, no rashes and no peripheral edema. A chest X-ray demonstrates bilateral pulmonary infiltrates and leukocyte count is 7,800. What is the most likely diagnosis? So let us see the first option, whether it's febrile non-hemolytic transfusion reaction or not. Answer is no, because in febrile non-hemolytic transfusion reaction, you will develop only fever. You're not going to develop anything apart from fever. And why the patient should have pulmonary infiltrates and why the patient should be in shock if they're having a simple FNHTR. So that's not the diagnosis here. And what about sepsis? Sepsis is a possibility because it can result in shock. It can result in pulmonary infiltrates because of ARDS. But again, the patient's counts are normal. Okay, the leukocyte count is only 7,800. So it's unlikely to be sepsis. And it's very rare to get sepsis with PRBC transfusions. Usual products that result in the development of sepsis is the platelet transfusion, because platelets are the ones that are stored at room temperature. And the third one, TACO. TACO is also extremely unlikely because TACO patients will have elevated JVP. And of course, there will be some evidence of volume overload state, like CKD or heart failure patient. And many of them will have normal or increased blood pressure. They will be hypertensive. So this patient is having a normal JVP, they're having hypotension, and there is no evidence of volume overload state, no history of heart failure or CKD. So it's unlikely to be a transfusion-associated circulatory overload in this individual. And more often than not, the PRBCs are very notorious for development of TACO, transfusion-associated circulatory overload, because the volume of the PRBC is generally higher than other blood products. That's why. So in patients who are already volume overloaded, PRBCs are the ones that are going to predispose to TACO. So then what about TRALI? TRALI is the right answer here. So why? Because TRALI is something that develops acutely within 6 hours after transfusion of a blood product, and the most notorious blood product that is going to result in the development of transfusion-related acute lung injury is FFP. Even though it can happen with any blood product, but FFPs are very notorious because you need to understand the pathophysiology. Pathophysiology is not clearly known, but we believe that the antibodies in the donor, these are called as granulocyte antibodies. Granulocyte antibodies that are coming from the donor. Okay, they're coming from the donor, not in the recipient. So these donor granulocyte antibodies are the ones that are thought to be the reason for development of lung injury. That is TRALI, transfusion-related acute lung injury. So we know that FFP is the one that contains antibodies as such, maximum amount of plasma components in the form of antibodies. That's why FFPs are very notorious for causing TRALI compared to PRBs. But it can happen with any blood product for that matter. FFPs have a higher risk and they're more notorious. And apart from that, patients will have hypoxemia, patients will have pulmonary infiltrates, and patients will be having shortness of breath. Sometimes in examination, they can have crackles. These are non-specific findings. These findings can happen in TACO, these findings can happen in sepsis, these findings can happen in many other situations. But what will make you diagnose TRALI is your hypotension with a normal JVP and happening acutely within 6 hours of transfusion of blood product, especially plasma product like fresh frozen plasma. So the right answer for this question is simple and straightforward, and it is transfusion-related acute lung injury.
Subscribe and press the bell icon so you never miss an update from PrepLadder.